All right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Dr. Brandon Gumbiner. Thanks for joining me.
Hey, thanks for having me.
Yeah, absolutely. So you are a residency director in the middle of the United States, not too far away from where I sit right now in Illinois. How long have you been the residency director there?
I took over as director in 2018, so it's been 7 years.
Awesome. So that's a big job. We'll dive into all that here soon. But why don't you give the people a little quick background about who you are, where you came from, and how you got to be where you are?
Yeah. So I grew up in Northwest Indiana, in the region. They call us region rats. But grew up there, did my undergrad work at Indiana University in Bloomington, Indiana, and then went straight from there to Shoal. I was a Shoal grad in 2007. Did my residency at what was North Chicago VA and St. Joseph Hospital. That was combined. It doesn't exist that way any longer. They're two separate programs now.
Okay.
Did residency there, and then came out, had kind of an interesting career path. I spent 1 year practicing in South Bend, Indiana, and then moved out here to Dixon and practiced here from 2011 to 2015. And that's when we started the program. Left for a few years while my wife was working on her PhD, actually back to Indiana University. And then came back in 2018. I've been here since.
Nice. So you went to Indiana. My wife went to Purdue, so she hates you.
Ooh,
and I went to Iowa, so I hate you too.
Well, we're off to a good start.
Yeah, over 2. I don't know what to tell you. No, we love Indiana. We know the area quite well.
Yeah.
So, when you take the leap to be a residency director, some come by it, because they really want to do it. And some people come by it because you get tapped on the shoulder and said, hey, we really need you. We really want you. And maybe it's some of both. But when you take that leap to become a residency director, what goes through your head? Obviously, there's a lot of responsibility there, and that can take up a whole lot of your time. So what thoughts did you have when you first were interested in becoming a residency director and wondering whether that would be the right fit for you?
That's a great question, Jeff. Honestly, and I think historically I've always kind of been this way. I'll set a goal and I work towards it. And, I decided from a very early age I wanted to be a doctor, and then I kind of let life help me down that path. And I decided my goal was to be a residency director as a second-year resident. And it was because that was my first taste at teaching.
Sure.
Because you're getting to guide and mentor the first-year residents. And I enjoyed that so much. And I don't know what your experience was like during training. I had ups and downs. Some attendings were great and I had good mentors, and some were like you learned what not to do, right? And being there for my co-residents or being there for students that were struggling because they're in an educational environment where they're not actually getting taught anything, I found rewarding, and I found helpful, and I really enjoyed and found a little bit of a knack for explaining things in a way that people could understand. I'm not going to talk above you. I'm not going to make it hard for you. Let me see if I can simplify it for you. And so I've always wanted to do it. And I like that role. I like the sort of a leadership role. And when that opportunity came, I jumped on it. And I think that, I don't know, but if students listening know about the culture of our program, I mean, I think it's the greatest strength of our program. And we create that culture where it's a safe place to learn. It's a safe place to ask questions, but we're also going to push you, and finding the balance between doing both in a respectful, tactful way.
Absolutely. So it is OSF St. Catherine in Dixon, Illinois, for anyone wondering. You and I glossed over that because we both know that. But anyone listening and hasn't heard the Dean's Chat, OSF St. Catherine, Dixon, Illinois. So you mentioned about the different levels of teachers in residencies. So I did my residency in Pittsburgh, and we had some of the best attendings that I think are some of the smartest people: Pat Burns, Jeff Manway, Nick Lowry, among others. But we also had some little like peripheral attendings. And I remember one time I was scrubbing a case. I think I was a first year, and we were doing some perineal tendon work, and we were dissecting And the attending points at a structure and he goes, "What's that?" And I was like, "Oh, that's the peroneus brevis." He's like, "Nope, that's the longus." And it rattled my brain because I thought, wow, I am the dumbest person that's ever. How could I not know that? And I went home and I looked it up and I verified, and yep, I was correct. And it's just
Yeah.
one of those examples of like, yes, there are people who are born to teach, and there are people who aren't good at teaching or maybe shouldn't be involved in teaching certain things. So I think it's interesting that you found that passion at such a young age, because some people, I think it takes time to get out on their own before they realize they want to even be an attending, let alone a residency director, because that does take up a whole lot of extra time. So tell everyone what your academics were involved tonight.
Yeah. So today was a cadaver lab. In our program, every Wednesday afternoon is set aside for academics. So basically from noon to 5. And we try and do a cadaver lab every month. So today was a cadaver lab. We were focusing on tendon repairs, tendon transfers. We had some company representatives that brought different anchors to use,
Mhm.
and we go through those techniques, and we go through a lot of dissection.
Yeah, that's really good skills and opportunity for the residents, because there's this weird slippery slope there sometimes when industry gets involved. Industry is relying on us and we are relying on industry because they come with a big checkbook. They bring whatever it may be, products and samples, and sometimes they'll sponsor cadaver labs. And if you've ever been to a big conference, you walk in, you see their names everywhere. They make kind of the wheel go round, if you will. But I think it's important for residents to be able to use different industry products at a younger age and figure out what all is out there. There's some programs that only use product, or I should say company X. And then when they get
Hmm.
out in the real world, they have had no exposure with all these other things that may or may not be better. It's not about what's better, it's about understanding your options and what you can use in certain scenarios. So, how do you
Right.
decide which companies or which products to expose the residents to?
Yeah. It is. that- This could be a whole nother podcast, quite frankly, uh, about that whole aspect of things. But you're also kind of stuck too when you work for a hospital system in what you're going to use, and they contract with certain people.
Yep.
And for us at OSF, we have contracts with certain companies, and
Hmm.
it's kind of one hand feeds the other. And so they're the ones that sponsor a lot of our academic sessions. That said, our residents work with other attendings in other facilities that
Hmm.
have different contracts and different abilities. So they are using different products with different people
Sure.
quite frequently. Um, but yeah, it's fairly limited to who's willing to pay. We have a new thing with OSF, because OSF purchased our hospital in January, so that's a new parent organization.
Yeah.
But a lot of resources have come with that. It's been exceptional, and their main facility is in Peoria, Illinois, and we have access to a lab there.
Hmm.
Anytime we want it, we just have to book it a month in advance,
Sure.
and they've got instrumentation and things there from all sorts of different companies that we can use, and it's supposed to be pretty non-biased. And so we've
Sure.
been taking advantage of that too.
Absolutely. Every experience
Mhm.
that the residents get is for the better. I think some of that kind of goes out the window when you say, because it's a little different. My wife teaches at the school, and they have to be very careful with which companies they let involve the students. But when it comes to residency, I think it just benefits the residents to have a broader understanding of what's out there and what they can use when they will be out there on their own.
Mhm. Yeah.
When it comes to teaching, how do you handle that in the OR? Because sometimes it's difficult to trust the resident to take the knife or do certain things because it's your patient and your responsibility. So, how do you handle that when it comes to the OR, and more specifically, what your thought process is? Not physically how you hand them the knife, but more so your thought process of what goes into that.
Yeah. Also a very good question. I think yeah, I'm such an advocate for hands-on training. I think that is the purpose of a surgical residency program.
Yeah.
Um, I know in my residency, I mean, I logged hundreds of cases. I probably had 600-700 cases that I logged in residency. If
Mhm.
you asked me how many of those did I truly do skin to skin, it was a smaller percentage, way smaller percentage. It was a lot of, here, you make the incision. Okay, let me do this work. Here, you put the screw in. Okay, now, and it's this hodgepodge that then when you come out into practice, you're learning on your own. And so what I found, I actually, in my third year of residency, it became real for me that, oh, shoot, I'm going to be doing this in a year.
Mhm.
I need to know every detailed step of everything. So I took it upon myself to start doing write-ups. And the write-ups weren't copying it out of a book. It was, okay, I'm in my head. All I've got in front of me is a sheet of paper, and
Mhm.
I'm going to picture myself doing the surgery. And what am I going to do step after step? What instruments do I need? And I do that with my residents. And we'll do the night before, you're going to give me that write up. And my residents know, particularly the first years, no write up, no case. And so if you come in and we're going to sit down and I'll take the extra time and you take me through that case step by step, you
Mm.
tell me exactly what you're going to do because then I know you've already done it up here.
Yeah.
And then when we get in there tomorrow, you're not going to surprise me by doing something I didn't know that you weren't doing. And if you hit a
Yeah.
step that you don't know what to do, then I know, okay, here's where I'm going to teach you. And that's been really helpful.
I think that's a great way to approach that because, I've joked before, any monkey can do surgery. If you literally, maybe not literally, I shouldn't use that word. That's an overused word. Perhaps if you had a really well-trained monkey and you handed them the scalpel and you made an incision right here and okay, then you do that. And I'm telling you, okay, do this, do this, do this, do this. That's the easy part. Kind
Yeah.
of. A little repetition, a little practice, you understand how to do those things. The understanding is, okay, why are we making the incision in this position? Why am I not making it 1 centimeter to the right or 1 centimeter to the left? What happens if there's an anatomic anomaly and there's a vascular branch in this area? Now what are we going to do? And being able
Right.
to adapt on the fly. But at least if you have that game plan in your head ahead of time and you understand, okay, it should go like this, because no surgery, I don't think, I've done many, many myself, goes exactly according to plan. It's all just a little bit
Mm-hmm.
different, a little bit off of what you'd imagined in your mind. Did an ankle fracture yesterday. I did an ankle fracture today. They might look very similar on paper, but literally on the screen, I should say.
Mm-hmm.
But they're completely different when you get in there, and the mobility and the reducing the fracture. Oh, this one has more comminution than I thought. So you do have to be able to adapt on the fly. But I think the way of approaching that makes a whole lot of sense. And it gives you some confidence in them that they do understand. They have a game plan in their head. You're not just assuming that they know what's happening. You're actually making them verify that they understand what's happening.
Right. And one of the nice things is they're able to take that write up, they put it on the back wall, and our scrub techs and our circulators know what they need.
Sure.
And so that makes things move smoother. But then also at the end of the case, when there was that variation, they can go back and write down, oh, well,
Mhm.
this was different. And then they
Yeah.
keep that and they have a book. And 5 years from now, when they're doing a case similar and they're like, how did we used to do that? They've
Mm.
got those notes,
That's great. Great resource for them. So we
Yeah.
talked about the benefits of teaching. What are some of the difficulties of being involved in resident teaching and involving that? Because I take third year students. They are fresh, brand new. They know a little bit and they think they know a lot. It's
Mhm.
difficult. Um, but trying to incorporate them into my day in terms of teaching and seeing patients and doing surgery and all that stuff, no one would argue that it doesn't slow you down. I can do this a lot faster.
Yeah.
I could do this maybe a lot better. So you do have to factor that into when you are agreeing to teach younger people. So what are some of the lesser, I don't want to say cons, but maybe some of the more difficult things involved in teaching?
Yeah. Oh, that's a great question.
You
I
love
think
everything. That's fantastic.
I
You
do
love
love
it all.
I love my job. I love teaching. I love mentoring people. I think anything like managing people, sometimes your expectations or your drive isn't mirrored by the people doing it. And
Sure. Yeah, yeah.
how do you
That's
motivate
tough.
someone that doesn't want to be motivated? Or how do you motivate someone or help someone when they're dealing with something else in their personal life that's
Yeah.
getting in the way of what your goal is trying to be? You
Yeah.
know, ul- Ultimately, all of our residents that come through, I'm trying to get them from point A to point B. And I just tell them, we're rowing in a boat and I'm going to get in that boat and row with you for 3 years.
Hmm.
And I'm trying to help you get there, but there's things that can get in the way of that, and it makes it challenging.
Yeah, that's an interesting perspective because when we
Yeah.
think about residency training, you're just thinking about clinic and surgery and cases and volume and logging and academics and all that stuff. But you're right. These residents, in your case, do come with a social life, a family, difficulties at home, whatever it may be. So I didn't necessarily think about that. That's a good perspective.
Mhm.
Podiatry has shifted from no residency to 1 to 2 and now to 3. What are your thoughts on the current residency model? You feel like when you ship a third year off into the real world, they're ready to go? Feel like, some of them could benefit from some fellowship? Do you think we should be doing a 4 year? Do you think 3 years is too much? What are your thoughts on the number of years and the how you feel residents are ready to get out into the real world?
Yeah. I think 3 years is appropriate. The way our program is, I've felt very confident about everyone we've graduated in the last 7 years. Um,
What about 8
and
years
it
ago? I'm just kidding.
it oh.
I'm joking.
Yes.
I know you've only been
Um,
doing it 7 years.
yeah.
I'm just kidding.
No, it's been good. I think one of the things I talk to students about a lot, and this is some personal opinion, but podiatry has become very much a surgical profession.
Yeah.
And and I think one of the hard things is that the 3-year training across programs is not equal. And I think that there's some
Yep.
thought among students that it is. And then what happens is, well, you end up doing a program where they're meeting numbers because they are just first assisting, but not actually doing any of the cases,
Hmm.
or they're watching somebody do surgery and then they come out and they're not capable of doing it. And so then they're probably trimming nails somewhere and then they're mad and they're writing on blogs and doing stuff about how podiatry ruined their life. Right.
Oh, I know these people well.
Yeah. And,
Not
and,
personally, I just know them
yeah.
from their online presence. It drives me absolutely insane.
Yeah, and it hurts our profession, and the real thing, just like anything, I mean, it's effort you put in, and that effort starts when you're a student. And if you're going to get the best training and seek out the best opportunities and take control of your life and your career, you're going to have a very rewarding career. It's an excellent profession. You make a
Hmm.
huge difference in the world. But unfortunately, without training being equal across the board, it's hard to say. I can tell you very confidently, 3 years here at our program will prepare you for pretty much everything you want to do.
Hmm.
I don't know about other programs, you know,
Yeah.
and there's tons of great programs. I'm not saying that, but you need to be mindful of the training you're getting.
I would imagine that's not unique to podiatry. I would imagine there's
Mm,
really, really good orthopedic residencies and maybe some that are not quite up to snuff. And so, uh, ENT, derm, go down the list. I'm sure they're not. You can't have all residencies be equal because they're going to have different attendings, different experiences. The different quality of residents that they're getting is going to vary. So you're right. Maybe we're approaching that maybe a little from the wrong aspect. Maybe it's not a magical number of years. Maybe it's a magical amount of competency, which, we have board certification, and some people say that it's too difficult to get board certified. But I think we do have to hold ourselves and each other to a high enough standard that it actually means something to get board certified.
mhm.
If a 3-year residency is just checking a box, not saying that's the case, but if it were, then having some sort of standardization across the board is important. So
Yeah,
um so I heard you on Dean's chat. You give out walk up songs. Would you
yeah,
like to explain that a little bit?
yeah. So I usually let the residents pick the music. If they're doing the case, then they get to pick the music that we listen to in the OR. And I love
That's a
music.
little dangerous sometimes, isn't it?
It can be, yeah, especially when people pick Tibetan throat music.
Do you get
But
veto power? Do you get like, all right, no, I get 3 vetoes. Like you get to choose, but I'm gonna cancel it if you get too crazy.
pretty much the scrub techs and the circulators get that veto power because
Yeah,
they're
I'm
like, we're
sure
not
they're like,
listening to this.
nope,
Uh-uh.
absolutely not. Yeah.
But I don't know. I had a resident. She graduated this last year. She's actually a fellow at the core
Hmm.
in Phoenix, and she she's cool. And when she walked into the OR that morning, I was listening to Rage Against the Machine, Killing in the Name of.
Mm.
And I was like, you know what, Dr. Sarah Kubik, this is your song. And it's so not her song. She is so nice and kind. And like, it's just this contradiction. But I'm like, when
Yeah,
you're in the OR, you're a boss and you need this song. And
that's
then
funny.
that started it. So I started picking songs for all the residents just based off, I don't know, their personality in the OR.
That's funny.
Yeah.
Uh, Speaking of things that are fun, you guys do something that I think is the most unique and one of the coolest ideas that I've ever heard of, which is the escape room idea. Tell us how the idea came to be, and then we'll dive a lot further into that and what it is. But how did you come up with the idea?
Yeah. Yeah. Thanks for asking that. Actually, we have, I think next month, JATMA, we have an article being published on it. I think
Really
it comes out next month in JATMA. Yeah.
cool.
But Nathan Maurin, one of my partners, and he was a graduate from Des Moines. He and I were trying to come up with an idea, honestly, to generate some extra money to send our residents to all of the extra courses we send them to.
Yeah,
And we've seen lots of labs and, kind of the same stuff over and over. And I said, we got to do something different. And we had chatted about escape rooms. They've become popular in the last 10 years or so. And I said, boy, you could sometimes being in the OR is a lot like that. You're trying to figure out, you've got a problem in front of you. You got to figure out the clues. You got to diagnose it. Something doesn't go right. It changes your train of thought. Um, and it puts the pressure on you. And I thought, the other cool thing about it is that if you have residents and students in a lab, it's one thing to say, okay, do a lapidus. Okay, do an ankle fracture. But if you
yeah.
present them with the pathology and they have to come up with the treatment, that is more true to real life than anything. And that's kind of how it came about. And we thought, well, we could have some fun with it too.
Yeah, so for anyone that doesn't know what an escape room is, you go to this experience and the goal is to escape the room. Maybe it's one room, maybe it's multiple areas, but you have to find clues, solve them, maybe, descramble some words or figure out the code to a lock or a password on a computer or something. And each step kind of leads to another clue, and you logically move along until you're able to escape. Interestingly, we had some friends over recently, and I thought that it would be fun to do a virtual escape room. So I looked it up, and they exist, and you can get this experience, and it wasn't terribly expensive. It was like $25 or something, and you could do a virtual. I threw it up on the big screen. We all sat around, and it was kind of like a Sherlock Holmes thing, and it walked you through, and you had to like click on this, and it gave you this letter that someone wrote to someone, and you had to read the clues and figure out what else to do and put things in order. And it was really, really fun. And so doing something like that, kind of brain teasers, puzzles,
Mhm.
clues, things like that, and incorporating that into a medical capacity like you guys have done, I think that is just one of the coolest things that I can think of. And it seems like it's been growing and getting a really good response. You want to talk about that and the growth of it recently?
Yeah, no, it's been great. And it is fun too, Jeff. There have been cases in my career where I feel like I'm in an escape room. I just need to get out of this room. How do we get this fixed and get out?
Yeah, me too.
So there's some
Yeah,
truth to that.
yeah.
But yeah, it's been great. Our first we aimed to roll it out during COVID actually. So
Mm,
we were limited. In our very first year, I think we only had 25 people there. And this last year, we had close to 150.
wow.
Um, we've had a lot of interest from students. We've had some Des Moines students come out. We get a lot of Shoal students because we're closer to Chicago.
Yeah,
Um, and then pretty much all the residency programs in the Chicagoland area participate. We've got some residents from Indiana that come, some from Wisconsin. Um, yeah, it's been a lot of fun, and we've gotten a lot of good feedback. It's just a fun environment to be learning in. Um, so yeah, it's been great growth. Some industry is there, but we have a lot of different industries. So
hmm
I think this last year we had 8 different companies
Hmm.
sponsor, and they can highlight different products, and all the participants can use it in the lab to fix whatever their case is.
Can you give kind of a broad example of how you would implement the escape room ideas to surgical or non-surgical, just medical cases? Can you walk people through of kind of some of the experiences that people have when they're doing the escape room?
Yeah, sure. And we've done, every year we've done something different. Our second year residents are always in charge of putting it on, and
Hmm.
I give them quite a bit of creative freedom. It was really fun. It didn't work very well, but a few years ago we did videos.
Hmm.
So if you go to an actual escape room, there's usually an intro video that kind of gets you in the mood and tells you what's going
Sure.
on.
Yeah.
So we made up these characters and acted out characters like
Huh.
anxious Amy, or just some of the patient profiles that you can think of in clinic that are hard
Yeah.
to deal with.
Sure.
Uh, we had those people come in and we acted those out.
Yeah.
And in those acting out, or as we do it in the last few years, we just give you a history. There's clues in the history, like 67-year-old male falls from a ladder and has suffers this injury. And in order to find the X-rays, well, guess what? You've got to use a black light to find the clues around the table to unlock the lock that opens the box with the X-rays in it.
Hmm.
Um,
Yeah.
or same thing to get your scalpel blade, maybe that's hidden somewhere in this little work area, and in order to find out where it's hidden, there's clues in the history to find it.
Yeah.
um, and then so then you work through and you get those x-rays and you decide what you were going to do, and we have an attending who's there to help guide you. Some of the students haven't put a plate or screws on before or done anything, so they're there to aid in that. But as the
Uh-huh.
participants, the students and residents, they're driving the treatment.
So how do you win? How do you escape? What is the conclusion of the event?
Yeah. Also, we've done that differently each year, and it depends on our residents. We had some very competitive residents a few years ago that there was a scoring system, and there were
Mhm.
judges, and we went around and we scored you based off of how much time you took.
Okay.
And then there was a quality score, and then also a teamwork score. How well did you work as a team? And all that went in, and then we had winners, and we gave out gift cards to the winners. This last year, our residents were very non-competitive that put it on and they said, we don't want competition. And
Mhm.
so it was still more of the, well, did you escape in time? So we typically have either like an hour and a half to 2 hours, and it starts at 8 o'clock. So at 7:59, I'm like, okay, in 3 minutes or 3 seconds, 3, 2, 1, open your envelope, go.
Mhm. Yeah.
And if you don't finish in time, you don't finish in time. But if you do finish in time, then those people that finish, we usually give them an award of some sort.
Nice. That sounds
Yeah.
super fun. That's a hats
Mhm.
off to you for the creativity aspects, but also going the extra mile to make education fun. That was one of the main goals of me doing this, was making education fun and entertaining. So I think that's fantastic. So congratulations on that, especially with the growth. So that's awesome.
Well, thank you very much.
Yeah, I forgot to ask you, what would your walk up song be?
Oh man.
Has anyone ever given you a walk up song?
No, they haven't. And I don't know. My musical interests are, I mean, I listen to just about everything. I really don't know. I really don't know what my song would be. Oh,
I heard you on Dean's chat. I think you said you like Foo Fighters.
oh yeah.
So it's got to be My Hero by Foo Fighters. So when all the residents say, "What's your walk up song?" you say, "I'm your hero." So My Hero by Foo Fighters.
It's a little egotistical, but yeah, that's a
It's
great
perfect.
song.
It's perfect. What are some of your favorite cases to do? We all have our favorites and our least favorites. We'll not focus on the negative. We'll leave that for a different time. But what are your favorite cases to do?
Yeah, we're fortunate. We get to do a lot of trauma here. We have a great relationship with our orthopedic department. Being in a rural setting, we get quite a bit, and so I like doing ankle fractures. Um, I like doing ankle scopes, ankle arthroscopy,
Hmm.
and in the last, I guess it's been about 6 years now, I've been doing a lot more peripheral nerve surgery,
Sure.
and have found that to be really enjoyable and interesting. Um, so I would say those three.
I like trauma. Nerve stuff to me is very difficult. Here in a little bit, we'll jump into that into a case of a nerve issue, but nerve stuff can be very difficult. Those people can be very debilitated, and sometimes they've been brushed off by other people, and and not saying they're making it up, but sometimes they're very frustrated, and those can be very difficult, whether it's post traumatic or what, there's 10,000 different etiologies for peripheral nerve pain, systemic or peripheral. But those are very difficult cases. Let's say you have a patient come in who complains of some nerve type symptoms. This is for the younger people listening. I always say that if I hear some magic words, I start to think about nerve, numbness, tingling, burning, electric shocks,
Uh-huh.
anything that's shooting. All of that makes me not nervous, but makes me suspect literally nerve
Yeah.
issues for people. So what is your general workup, starting with that patient who has that complaint that this doesn't seem like tendonitis or a stress fracture or something, it seems different? How do
Right.
you march down that pathway, and what, do you use EMGs, do you use NCVs, what are you using to just talk broadly about those nerve patients?
Yeah. And I think it's hard to pinpoint like one nerve issue per se, but you absolutely hit it on the head. I mean, these patients that are having nerve pathology, those are the complaints. It's burning, tingling, shooting sensations.
Hmm.
Sometimes it is kind of a vague presentation, but the importance of a clinical exam, can't be stressed enough. And when you're doing a good, thorough clinical exam, you're able to rule these things out. I mean, I've had patients where instantly, based off their history, I'm thinking, okay, maybe this is a tendon issue, this is a musculoskeletal issue. But you can kind of quickly find out by listening to that history and that physical exam that they're not tender on those areas. Then you start thinking, okay, is it burning? Is it tingling? Then what nerve roots is it following?
Hmm.
It's not easy, and by no means could I even sit here and say, oh, I'm an absolute expert and everybody that comes with nerve pain we're able to get better.
Yeah.
But I can tell you, having some experience and having done the AENS courses, I've been able to find pathology and treat pathology that was seeing me that I wasn't seeing it earlier on in my career.
Sure.
um,
Yeah, that's tricky. So do you use EMGs, NCVs? Do you refer to neurology? They refer back. I always get kind of like stuck in circles with like, well, could be coming from your back. It could be coming from peripheral. Is it diabetes? Is it a combination of all those things? And kind of trying to figure out, okay, where do I start? No one's ever
mhm,
going to say that more information is wrong. So getting those tests, I think, can sometimes be helpful. But in my experience, which is not, I would not call myself anywhere an expert with nerve stuff, so I could be wrong, but sometimes those broad studies, and I equate it to vascular studies. So vascular and nerve studies are really good at picking up big issues. So in the
mhm,
vascular, it's going to pick up a femoral arterial blockage or superficial femoral or even the large arteries in the calf. But when they get down into the pedal arch and the digits, it is not good at picking up vascular issues down there. And the same could be true for nerve issues. It's good at picking up
mhm.
large nerve issues, but not so good when we get quite distal. What are your thoughts on some of those tests?
Yeah. Most of the time, I'm getting an EMG NCV, no, if we're going to treat peripheral nerve something.
Hmm.
However, those tests, there is quite a bit of subjectivity to them as well. And it's not often clear as day. And I've had patients that we're getting completely normal EMG NCV studies, but we know that there is a peripheral nerve problem
Yeah,
based off of that clinical exam. So, it's always correlate clinically, right? When they tell you that in the reports,
I love
well, you
that.
got to correlate clinically. We know that there are certain compression points. So if it is a nerve entrapment, is it common peroneal nerve entrapment at the fibular head? Is it
Hmm.
superficial peroneal, 10 to 20 centimeters above the lateral aspect of the ankle, where it pierces the deep fascia?
Hmm.
Deep peroneal nerve commonly gets entrapped in the dorsum of the foot, or anterior ankle.
Hmm.
Tarsal tunnel, we know. And so
Sure.
it's identifying your Tinel sign, your Valais sign. We're doing sharp, dull pinprick. We're doing vibratory. We're doing light touch sensation. All of those things. And in addition to that, there's times that we're doing diagnostic nerve blocks. And I
Yeah.
probably get more out of diagnostic nerve blocks than anything,
Yeah, I agree.
But even those sometimes, you're going based off the subjective findings. And many times, Jeff, I'll have a conversation with the patient where I say, okay, here's all the data points. Here's what we have. Here's what we know. Here's what we don't know. And now we're going to have a conversation about what are the risks versus benefits. And if
Mhm.
it's a nerve entrapment issue, okay, with what you're dealing with, here's where I think it is. Here's what's going on. I can't give you guarantees, but the benefits probably outweigh the risks.
Yeah.
I've definitely had patients where I say, hey, look, you potentially have a severe neuroma or you've had a chronic neurotomesis injury. Listen, we're probably taking greater risk than potential benefit going at this. We're going to get you to pain management, maybe talk about spinal cord stimulator,
Yeah.
things like that. So
Sure.
it's there's a lot of subjectivity. I think that's the hard thing about treating peripheral nerve work.
Yeah.
There's a lot of subjectivity to it, and also we don't have direct mapping. I've had patients that have anomalies that I've numbed them up, and I think we're going to do a nerve transfer and numb them up, and guess what? They have some weird nerve branch that we didn't
Mhm.
even see, and they still have feeling in an area that we thought they'd have numbness. You know.
Yeah, those patients can be highly complicated for the reasons you just mentioned, and then sometimes they're attached to a patient that is highly complicated, and when those 2
Mhm.
things come together, it's especially complicated because 'cause they're usually not. I'm not an expert in the field, but it doesn't tend to be, a teenage boy. It's
Mhm.
a lot of middle-aged females, and I don't understand why that may or may not be, but those type of patients are very difficult and they want to get better, but there's a lot going on, and sometimes you can help them, and sometimes, like you said, it's difficult and it may be on something that you can do. At what point do you involve lumbar x-ray, not that
Mhm.
you're ordering it or treating it, but involving someone to work them up from a lumbosacral low back aspect as well?
I would say in my practice treating peripheral nerve, I feel much better when those symptoms are more specific in terms of a specific nerve root or nerve area. It's
Yeah,
definitely, oh, this anterior lateral part of my leg. Oh, it's
sure.
definitely the plantar aspect of my foot.
Right.
When they come in and it's more global, well, it hurts here, it
Yeah,
hurts everywhere.
both sides
And
all over. You're like, okay,
yeah,
I'm not going
and
to be
and
the one
those
that's going to solve this.
exactly. Yeah. And that's when we're sending out and working that stuff up. I've also had patients, though, that do have unilateral nerve issues that maybe we are catching in the NCV EMG that there's potentially something going on more proximal.
Mhm.
And if we question it in any way, shape, or form, we're making that referral before we do anything surgically.
Absolutely. Speaking of nerves, you want to hop into that nerve case?
Yeah. I'll show you an example of a pretty cool case, actually. Okay. So I've actually got two cases to show here, and I just think these are interesting. We do a lot of different nerve stuff, but I think this is interesting that probably earlier in my practice, I would have sent these patients to neurology. I would have sent them for a brace, but with decompression and identifying these areas of compression, we're able to help them. So this is a 29-year-old female, and she came with a cavovarus foot deformity. This picture was when she was 2 weeks post. All she did was stub her toe in a cornfield
Hmm.
and said she woke up the next day and you can see the cavovarus deformity on the left side. And she said prior to that injury of stubbing her toe, she was totally normal. She had no
Huh.
symptoms, no issues. And here she is. She does have burning and tingling along the lateral aspect of her foot and lateral aspect of the leg. We did some conservative treatment for her. We tried conservative treatment for about a month, doing physical therapy, neurogliding techniques. Um, and I think we put her on a course of prednisone to try and reduce inflammation and no resolution of the symptoms. They were all the same. She was getting pretty frustrated. So we planned on doing a common peroneal nerve and superficial peroneal nerve release. The EMG NCV did show slowing of the common peroneal nerve at the fibular head. And
Yeah.
here she is preoperative. This is a video, so we'll see if it plays here. So that was her pre-op, and we took her in. These are images of our common peroneal and superficial peroneal nerve release. And in this,
So
actually,
for
this is the
anyone,
only. Oh, go ahead.
so for anyone that doesn't do that surgery, what are your landmarks for um, guiding your incision placement?
So for the common peroneal nerve, you're going to feel the fibular head. And the best way to do that is to actually bend the knee about 45 degrees, because some people will actually feel the distal lateral end of the femoral head and think that's the fibular head. It's not.
Sure. Yeah.
There's another notch distal to that. And you
Mm-hmm.
can know you're in the right area if you look at the anterior tibial tuberosity and just move lateral from it. Your fibular head sits about the same anatomical level, and that'll
Sure.
keep you from being too proximal on that. And I go about one finger breadth just below that fibular head at an angle, because the common peroneal nerve kind of angles down, maybe 30 degrees or so. So it's a slight angulation is pictured here,
Mm-hmm.
to release that. And it's kind of a fun release to do. And there's 3 septums that we release as well, on the front part of the leg there, in between their intramuscular septums between the peroneus longus and the extensor tendons. And then the superficial peroneal, there's actually a great video and instruction by Dr. McKinnon, who's out of Washington University in St. Louis. She's a plastic surgeon,
Uh-huh.
and she outline these landmarks. But if you mark at 10 centimeters, 15 centimeters, and 20 centimeters proximal to the distal fibula, and at each of those marks, you move 3.5 centimeters, 4 centimeters, and 4.5 centimeters lateral from the anterior tibial crest. It puts you right in the area of the superficial peroneal nerve, and it typically pierces that deep fascia between 10 and 20. I've definitely seen variations of that, but typically that'll put you in the area. Okay. And so this video here, if it plays, this is the only patient I've ever seen this on. But after releasing the common, we went down to the superficial, and we already saw muscle fasciculations in the lateral compartment of the leg here, which was super interesting. And then when we, as all good patients do, she got all of her bandages wet the night of surgery. And so we got to see her day 1 post-op, which ended up
Oh,
being pretty cool, because this video is 1 day post-op and she's got full motion. I'll play that here.
so pretty instant improvement then, huh?
Yeah. And over the years, this was one of the first few cases we had done. And I probably do 5 of these a year maybe, but we
Mm-hmm.
had 2 in the last month, and both of those patients instantly in the PACU had full motion back, had
Wow.
resolution of their symptoms. So it's pretty cool.
Yeah. That's pretty um difficult for that patient because it's such a subtle onset. It's not a car accident, it's not a fall into a hole. It's just it could be such a subtle mechanism, and maybe some people are more predisposed to these issues and it doesn't take much to kick them over into the pathologic side of things, but it seems like such an innocuous injury that can cause such profound dysfunction for people. I'm sure they're confused by it.
Yeah, very much, very much. I'll show this other case here too if we have time, Jeff.
Yeah, for sure.
Uh, but this was a similar case, but much farther out. 32-year-old male. He had a 3-year history of this cavus foot deformity,
Hmm.
lateral ankle instability, foot drop post injury at work. And he'd been to multiple different people, and people just said, "Hey, look, here's an AFO for you." And
Hmm.
he's 32. He wants to play with his kids.
Yeah.
And I worked him up for the cavus foot. To be honest with you, I walked in and said, "Oh, okay, yeah, this is cavus foot. Here's what we're gonna do." And I got my book there for the Coleman block test. And then then it occurred to me, I'm like, wait a second, this is a unilateral cavus. And I started asking him more questions and got more involved with my clinical exam, and realized, hey, he's got neurological deficit here. We did our studies; they did show entrapment. It's always nice when they do. It definitely helps you feel more confident. And
Yeah.
so, we got a video here. This is him pre-op.
This is one of those times where it's really beneficial to have had people take both shoes and socks off. Because, like you
Yes.
said, you realized that it was unilateral. If you
Hmm.
didn't make him take off the other shoe and sock, you might just assume that it's a global bilateral structural cavus deformity. So sometimes patients complain, I have to take off my other shoe and sock. And yep, you do.
Yeah.
Today, yep,
I'm
you do.
I'm not just a left foot podiatrist. I also do the right foot. Yeah. Yeah, for sure. And that's a really good point, you know. And so then the second video, this is him a year out. So you remember this guy is 3 years, and I couldn't give him any guarantees. I mean, quite frankly, in the nerve world, if you have entrapment greater than 6 months, it's hard to say what sort of resolution you're going to get. And
Sure.
he had a lot of muscle wasting too from those 3 years of basically not moving. And
Interesting.
so he did a
Yeah.
year of physical therapy, and then here he is 1 year out. Yeah, so he basically had no motion of his right foot a year ago, and then here a year later, he has full motion back. And what I really want to point out to you is if you look at, can you see the pictures on there?
Yeah.
Yeah, so the left picture to the right picture, his cavus foot is completely resolved,
Yeah.
and we didn't do a single osteotomy on him. All
That's
we did were nerve
amazing.
releases. So no bone cuts, no Dwyer, nothing, and it completely resolved once he regained function.
Wow.
So
That's
really
so
rewarding case.
amazing. Yeah, for sure. I'm sure those people leave and are just like, wow. They think you are their hero.
I don't know about that. But, it's so, I mean, for our job, most of the time, we don't know how good of a job we did surgically for 12 weeks to a year out. And
Yeah.
these cases, it's amazing to have some instantaneous reward
Yeah,
when you see that.
absolutely.
Yeah.
Those are fantastic cases. Those are great outcomes for those patients. I think that, a lot goes into working them up, diagnosing, and like you said, diagnostic blocks and trying to isolate, okay, where's the problem? Is there a problem? Do I think I can help you? Here are the risks. Maybe I can, maybe I can't help you. I tell people sometimes with surgery, I know I can make you worse. I don't know if I can
Yeah.
make you better. I know I could make you worse. This
Hmm.
you may not, you may wish that you didn't do surgery. So we need to understand, here's what I think we can do with this surgery, and here are the potential pitfalls of doing this. And it gets even a little bit more sticky when you're involving nerves in those things versus bone or tendon. So those are great cases. Thanks for sharing those.
Yeah. Thank you.
We have a little bit more time here. You want to jump into a quick trauma case?
Yeah. That'd be cool.
I don't think you want to help me do my fantasy football, so let's make sure I pick the right tab here.
I don't think you want me helping you with your fantasy football.
Okay, fair enough. Fair enough. All right. So this is a lady. I just saw her this week. So it's not anything fantastic or unusual, but it's just kind of a pretty straightforward ankle fracture here. So 42-year-old lady fell down. She's an everyday meth user, and that always complicates
Ooh.
things from a pain control standpoint. Underwent close reduction in the ED. And so these are the post reduction films. A lot of times when I get pictures sent to me by the ED and their post reduction, I'm like, hey, that looks great. Let's splint that, and I can see them back in the office. This one made me a little bit nervous. This is the
Hmm.
post reduction film. So for anyone just listening, we have a transverse medial malleolus fracture, kind of a high Weber C distal fibula fracture, but kind of encroaching on mid shaft fibula, but pretty high fibula fracture, gapping at the syndesmosis and lateral translation of the talus under the tibia. But this one made me nervous from a medial standpoint. When I see that
Hmm.
medial side, I'm thinking that there's maybe some skin tenting there, and worried about that. I don't know. What are your thoughts when you see that? Would you let this sit for a few days and follow up in your clinic, or would you tell them to re-reduce it? And then I'll tell you what I did.
Yeah. So one nice thing here is our clinic is attached to the hospital.
Hmm.
And I think if they called over and this was their post reduction, I would say, hey, we're going to tee this up and just get it to the OR today,
Yeah.
and fix it.
So I told them to admit, and I fixed it right away, just because I didn't feel comfortable letting that sit for a while. And when they're so good at normally reducing it, and one looks like this, that makes me worry that there's interposing something, posterior tibial tendon or something preventing good reduction. And so letting that sit for a while just didn't feel like the right thing to do. And so you can see on the lateral here, she had this big posterior butterfly fragment too. So it wasn't just a simple fragment. And
Hmm.
I have some interop photos. I don't have them in here. I'll post the case to my Instagram at some point. But what are your thoughts when you see that kind of segmental comminuted fibula? Because obviously it makes it hard for us to get that back out to length because it's unstable.
Right.
What are your thoughts when you see that comminution, and what are your tips for trying to get length back on the fibula?
Yeah. Well, once I see that, I always think, well, these are going to be tough injuries. they're
Hmm.
they're they're tough to fix. They're tough to reduce, and quite frankly, the outcomes aren't that great. These types of patients, you're going to see develop, post-injury arthritis much sooner than some of the other rotational ankle fractures we see.
Hmm.
And yeah, there's a lot of little intricacies to fixing it. What I usually do with these, and what I tell the residents to do when we get in there, because usually once they're asleep and you're in there, you can slide that talus back over fairly well and pretty easily. But maintaining that length is the challenging thing. And I tell them, ignore everything at first. Put the plate, get a long plate, and put it on the proximal fibula,
Hmm.
and then reduce the fibula to the plate at the length you want it. And once that's reduced, then worry about the butterfly fragment. And sometimes they're small enough that honestly, I'll remove it. You don't need
Hmm.
it.
Yeah,
Sometimes this one looks a little bit bigger, so I'd probably try and get some screws across it to
sure.
fixate it. But I'm lining up. Obviously the length is the most important thing. So I'm getting that length by reducing it to the proximal fibula through the plate.
Yeah, I like that. In this particular case, I had some difficulty getting my length on my fibula. So I opened up laterally first at the fibula and tried to spin it down and reduce it. But because of the posterior butterfly fragment, I couldn't get my clamp to hold the proximal segment to the distal segment, because right where the fracture was, there's a big butterfly fragment. So there were three pieces. And so normally I put the clamp on, I spin it down, I get my length, I clamp it, and off we go. But I couldn't do that. And so what I did is, I don't usually do this. This is why this one is a little unique, is if you look at the picture on the right, I'm pinning the medial malleolus, but you can see the fibula is significantly short because I haven't been able to get that out to length yet. So if this was my final film, I would say that's terrible. You did a terrible
Yeah.
job about getting the fibula out to length. But what I did was I went medially. There was the posterior tibial tendon
Hmm.
was interposed into there. I had to take a little a sen and pull the posterior tib out of the way, and then reduce the medial malleolus and pin it. And so I just pinned it and I left it, and then I went back laterally. And once I did that, it made it a lot easier to get my length, because on the picture on the left, you can see that the reducing forces are wanting, the talus is pushing laterally and wanting to shorten the fibula. And so as soon as you try to spin that, you have the posterior tibial tendon interposed medially that's fighting against me. You could spend 2 days over there trying to get your length on your fibula. You'll never get it. So
Yeah.
I think that was the important part of this case, is don't get stuck trying to do one thing for too long. Jump to something else, at least open up medially, see what's going on over there, pull the post tib out, pin the medial malleolus, and then you can go back to your lateral side. Uh, X-rays aren't fantastic, but you
Oh,
can,
looks
I
good.
cut it off at the bottom, but you can see that then eventually I was able to spin the distal fibula distally and get my length. And then the other interesting thing about this case is that I used a try not to use trade names. It's a cerclage system that goes around the fibula and it cinches down with a knot. So it's a
Oh,
non-wire cerclage system where you loop around the fibula and then cinch the suture tape around to maintain. It's not getting significant compression or anything like that. I
sure.
find getting screw fixation across these very difficult, because the screw wants to displace. You can put a clamp on it,
Mm,
but I've also put a clamp on it thinking I'm holding it in position and created a new fracture, because sometimes the bone is a little brittle. You clamp it down and all of a sudden there's a new fracture. Okay, now we got a mess. So sometimes I don't fixate these at all. I tell
Yeah.
people it's not going to fly away. It's in soft tissue and it's stable, but I put a cerclage system around it and stabilized it. But this one was a little bit tricky from that standpoint, just because of the posterior tib in the medial gutter and
Yeah.
not being able to get length on the fibula like I normally would be able to. So I thought those were kind of some interesting learning points for
Very
people.
much.
Yeah.
Looks good. I mean, your ankle mortise looks fantastic.
Yeah,
Yeah,
thanks.
nice job.
Yeah, I appreciate it. So obviously you said you like doing ankles. I think it's interesting that we mentioned it before that all ankles are not created equal. You see an x-ray, and I try to teach the students, and I do work with the resident here, that if you're going to read an x-ray and describe an x-ray to me, you have to pretend the person listening to you can't see the x-ray. I don't know. How do you teach your residents to read an x-ray and guide you, give you some information? Hey, we have this blah, 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 ankle fracture.
Yeah. Boy, I don't know. Usually we're in a pretty big hurry. So I actually
It's broken. We need to fix it.
That's kind of what it is. Here's the picture. It's broken. I want to fix it.
All right, let's go. Yeah.
Yeah.
No, and that makes sense too.
Yeah, but no, we'll get into the weeds on that sometimes. I mean, going through standard radiograph, just like you guys teach in school. But then, what's the functionality of it? What does that mean, right?
Mhm.
How are you going to fix it? What are the things you're noticing? What are the intricacies or the personality of that fracture that are going to translate to how you're going to fix it?
Yeah.
That's usually the conversation we end up having. Yeah.
Yeah, I think it's noble to be a residency director, so I commend you for doing that, because there's a lot of underappreciation going on there.
Huh.
I think I underappreciated my residency director, because it felt like, you're the residency director. This is your job. This is what you're supposed to do. You're supposed to teach me. You're supposed to let me operate on your patients. And that's not the case. When you get on the flip side of it, you realize, oh, okay, yeah, there was a lot of sacrifice there that went into that whole experience that I did not appreciate. It's kind of like when you're a kid and you take me to the amusement park, and you get me birthday presents, and you take me to the dentist, and of course you pay for it all. And then you get to be a parent and you're like, they are so ungrateful. Like they don't appreciate anything. Golly. And I'm sure I was the same way. So hats off to you. And I commend you for being a residency director, because there is a lot of underappreciation there.
Thank you. I appreciate that. I have really good residents, and it's I don't know, it's a good thing. But usually about 2 months into practice, I'll be getting a phone call soon from our most recent graduates, and there's always a phone call where it's like, I'm sorry for everything and thank you.
Yeah, it's like you come around on your parents too. Like, hey, I'm sorry. Those teenage years, can we just forget those? I appreciate you. So if anyone's interested in checking out your program, where would you guide them?
Yeah, we have a website, so you can actually just Google OSF St. Catherine. You can email me to brandon.r.gumbiner@osfhealthcare.org. That's real easy, and I'll get you in touch with our residency coordinator. But all of our contact info is online. It's super easy to get.
Awesome. How does the externships work? How many students are you seeing, and how many residents do you have per year?
So we take 2 residents per year. We take 2 students per month for clerkships, and they'll be designating pretty soon, I think. So
Are they? I have no idea.
Yeah.
I'm glad I don't have to worry about. I got enough to worry about.
Sure.
So I appreciate you hopping on with me tonight. I think this has been a fun time, and I think your program is fantastic. So I highly recommend anyone check that out if they're in that stage of their life. So thanks for joining me tonight.
Yeah, thank you, Jeff, and thanks for doing this podcast. This has been amazing. My residents listen to it. A lot of students listen to it. You're making a real difference in our profession. So thank you.
Yeah, absolutely. I appreciate you saying that. So I had a fantastic time tonight, and I'm sure we'll cross paths again soon.
Sounds good. Thanks.
All right. Thanks, everyone, for joining us on this episode of Pod Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.